time immemorial, psychiatrists, who were first called alienists, since they dealt with the mental and emotional aliens of our society, have searched for new methods of treating their patients. These sometimes have resulted in somewhat unusual devices, some of which are depicted in the slide that you'll see in just a second. I want to begin by talking a bit about the history and importance of various somatic therapies for mental illness. The 19th century was a period of profound change in American psychiatric practice. Due to the efforts of Dorothea Dix and others, large mental hospitals were constructed to provide asylum for people with mental illness. This resulted in the concentration at first of hundreds and then of thousands of psychiatrically ill persons in these large institutions, where there was very little of a practical nature to offer as therapy. By the turn of the century, approximately half of the psychiatric hospital beds were occupied by patients suffering from tertiary syphilis. This was known as generalized paresis of the insane, and the initials GPI were among the more common sites in psychiatric records of the time. Confronted by the specter of these multitudes of patients languishing in mental hospitals, there was great pressure towards developing new methods of treatment. Early in this century, the Austrian psychiatrist Julius Wagner Jauregg found that malarial-induced fever had a helpful effect on neurosyphilis. This discovery was sufficiently important to earn Wagner Jauregg the Nobel Prize in 1927. The success of this rather crude treatment modality, not to mention the Nobel Prize for its discoverer, spurred research in other somatic treatments for the insane. Understand that this treatment involved introducing the malarial parasite to people who already suffered from syphilis, so you can see that it was a fairly crude method of treatment. In 1928, only 6 years after Banting, Best, and MacLeod had discovered the compound, the German psychiatrist Manfred Sackel was using insulin to calm the irritability of patients withdrawing from morphine. 5 years later, this time working in Vienna, he reported using insulin to treat schizophrenics. Occasionally, when he gave too much insulin, the patient suffered convulsions, making this the first known use of convulsive therapy. By 1935, acting on erroneous data that seemed to indicate an antagonism between epilepsy and schizophrenia, the Hungarian neuropsychiatrist Laszlo von Meduna attempted to induce seizures in schizophrenics by injecting oil of camphor. He reported success in treating 10 out of 26 patients. It's unclear just what happened to the other 16. The difficulty of inducing seizures with camphor led von Meduna to use pentylene tetrazole, or metrazole, the following year. No discussion of somatic therapies for mental illness would be complete without at least a mention of psychosurgery or lobotomy. This was first performed by Igaz Moniz in 1935, and it is a therapy for which he received the Nobel Prize in 1949. I mention these two Nobel Prizes in order to highlight the importance accorded these discoveries by society at the time. Also in 1935, Ugo Ciletti, professor of neuropathology and psychiatry at the University of Rome, used electrical energy to induce experimental seizures in animals. Hearing reports of the chemical efficacy of insulin and metrazole convulsive therapies, he sent assistants to Budapest and to Vienna in order to learn these techniques. It was Ciletti who thought to replace the dangerous metrazole with electrical stimulation to produce the seizure. After extensive research on animals failed to show that electrical seizures created new neuropathology, he treated his first patient, a 39-year-old psychotic man who had responded to metrazole treatment a year earlier. The new method spread quickly, and by 1939 was accepted in the United States. ECT became widely used during and after World War II, and inevitably misuse occurred, as it has for all medical advancements, including antibiotics. The first report of the Group for the Advancement for Psychiatry in 1947 was a plea that, quote, the indiscriminate use of electroshock therapy be curtailed, unquote. This slide has far too much to read. I show it only to indicate that a scant 9 years after Cerletti's first treatment, there was already great professional concern about misuse. Public concerns began to be raised about mad shock doctors who would sooner plug you in than talk to you. Jokes circulated about the treatment. This is an example of a couple. By this time, the use of muscle relaxants and general anesthesia had produced a less terrifying treatment, which had none of the previous dangers of fractured vertebrae, but did have the new danger inherent in all general anesthesia. By the early 1950s, the development of neuroleptic and antidepressant drugs reduced interest in ECT. It wasn't until the mid-60s, when the limitations of these drugs became apparent, that interest in ECT again was raised. Throughout the history of the use of this treatment, the main negative feature has been the loss of memory and confusion that is sometimes associated with the treatment. The early machines used the sine wave form of electrical stimulation. This is the type of electricity that comes from the wall socket and undulates up and down 60 times a second. Looks a little bit like a snake. Because it takes a certain height or voltage to induce a seizure, and because the seizure is the therapeutic effect, all the additional electricity which is used to get up to that voltage is not therapeutic and simply contributes to an increase in the organic side effects of the treatment. An alternate waveform, first experimented with in the 1940s, but not readily available until the late 70s, is the brief pulse square wave. The slide illustrates the difference between these waveforms. As you can see, all the electrical stimulation is delivered at the seizure-inducing voltage in the brief pulse square wave format. Any electricity given below the seizure threshold does not help treat the illness, but does increase the cognitive side effects. Without making engineers out of you, it's probably worth noting that the sine wave utilizes a constant voltage technique, while the more up-to-date brief pulse square wave uses constant current, which is measured in milliamperes. So, one recent improvement in electroconvulsive therapy is the waveform. Another is in the placement of electrodes. In the late 1960s, it was noted that there was a significant decrease in organic side effects if the stimulus was delivered unilaterally on the non-dominant side of the brain. A little bit later, I'll go into some detail on the various unilateral placements. Right now, let's talk about the indications for ECT. As I said, initially ECT was used to treat schizophrenic patients, and considerable success was reported. However, the advent of neuroleptic agents in the 1950s has largely relegated ECT to a secondary treatment for this disorder. Today, major depressive episode is the primary indication for ECT. Over 80% of current ECT patients carry this diagnosis. Generally speaking, the closer a patient's presentation fits a diagnosis of major depressive disorder with melancholia, the more likely that ECT will be effective. In practice, 80 to 90% of such patients demonstrate a marked improvement, which is a considerably higher efficacy rate than with antidepressant medication. The presence of psychotic symptoms, which usually is a bad prognostic sign for antidepressant medical treatment, does not lower the improvement rate for ECT. Indeed, some writers indicate that the presence of mood-congruent delusions is one predictor of a good response to ECT. Other than melancholia and delusions, no one seems to have developed prognostic indices for ECT. Even though electroconvulsive treatment is no longer the treatment of choice for schizophrenia, between 10 and 20% of patients receiving this treatment today carry that diagnosis. Good controlled studies have shown that ECT produces remission in a large proportion of persons with acute forms of schizophrenia, especially if they present with a catatonic or affective component. In chronic schizophrenia, only about 5 to 10% of patients show a major improvement, although it's only fair to note that these are universally patients in whom the neuroleptic medications have already failed, and therefore these are, by definition, in the most difficult to treat category. Mania is the other diagnosis for which ECT is very effective. However, since mania responds so well to lithium and other agents, only about 3% of current ECT patients have this diagnosis. Pregnant patients, for example, in whom lithium might well be contraindicated, could fall into this group. The great usefulness of ECT is its safety. People in their 80s and their 90s have been successfully treated, as have pregnant patients and those with severe heart conditions. Indeed, there are no absolute contraindications for ECT, although severe medical conditions such as acute hepatic or renal failure, unstable aneurysm, and fulminant infections do come pretty close. Relative contraindications include intracranial mass, such as tumor, hematoma, or evolving stroke, in which the temporary increase in intracranial pressure would be damaging. In these cases, ECT would only be performed when methods to control the intracranial pressure, such as antihypertensives or steroids, have been employed. Acute myocardial infarction is another relative contraindication due to the increased cardiovascular stress during ECT. However, old MI is not a contraindication. Severe underlying hypertension should be controlled before beginning ECT. We should take a minute to discuss the adverse effects of ECT. First, naturally, is mortality. Various estimates place this between 1 in 1,000 and 1 in 10,000, or about the same as for general anesthesia alone. Studies by Kalinowski and others in the early 1950s using non-modified ECT, that is, without general anesthesia, showed a much lower mortality, but a higher incidence of fractures and other complications due to the tremendously powerful muscular contraction. Sometimes transient cardiac arrhythmias are seen, usually with a post-ictal bradycardia, which responds to increased anticholinergic dosage. I'm going to talk in some more detail on premedication in just a little while. Arrhythmias secondary to sympathetic hyperactivity can be controlled prophylactically using a beta blocker. Under some circumstances, metabolism of the muscle relaxant, which is usually succinylcholine, can be impaired. When this happens, prolonged apnea can be the result. Although this is really pretty scary when it's witnessed, it can be managed with good supportive care, which may include intubation and certainly will include positive pressure ventilation. By far, the largest area of concern is effects on the cerebrum, including confusion and amnesia. While most good test data conclude that cognitive functions return to baseline within 1 to 6 months after ECT, some patients report persistent memory problems. The same data reveal that most patients do not consider this to be a significant problem. Nonetheless, this must be clearly indicated in the informed consent. EEG changes include a slow buildup of abnormal slow wave activity over the course of treatment, which resolves in 1 to 3 months after cessation. In the early days, using unmodified ECT, spontaneous or so-called tardive seizures were occasionally reported. This led later to the suggestion that ECT might activate a kindling phenomena in the central nervous system, leading to new epileptic foci. Well, that would be pretty scary if it were true. Kindling, due to electrical stimuli, is described in the animal literature using electrodes implanted in the brainstem. Gradually, after repeated stimulation, the seizure threshold is reduced to the point of spontaneous seizures. Well, as anyone who has administered ECT knows, exactly the opposite phenomenon occurs clinically. The electrical stimulus necessary to produce a seizure frequently increases over the course of treatment. This is not simply an anecdotal finding, but is supported in controlled studies in the literature. For example, Green in 1960 found that the current necessary to induce a seizure in 24 out of 39 cases increased and showed no change in the remaining 15. Spontaneous or tardive seizures may have been a result of hypoxia before modified ECT with pre-ventilation with 100% oxygen was adopted as a standard. In any case, we don't see them anymore, and it seems clear now that they do not represent an example of the kindling phenomenon. Frankly, I'm hesitant to attempt a discussion of the theoretical basis for ECT because there are so many theories, some of which contradict others. In the early days, the mechanism was thought to be behavioral. It was felt that the acute amnesia produced by treatment might well be a factor, since many patients tended to forget just what it was that bothered them before treatment. However, recent studies with unilateral non-dominant ECT have demonstrated simultaneous improvement in both memory and depression. Pathological slowing of the EEG was thought to be a factor, but this now also shows no relation to improvement. So you'll understand just how far afield some of the earlier theories got. It was semi-seriously suggested that the sexual orgasms experienced by some patients were the truly therapeutic element. Modern theories can be summarized by dividing them into neurochemical, neurophysiological, and neuroendocrine mechanisms. The catecholamine hypothesis of depression provides a major theoretical element in the understanding of treatment. Both antidepressant drugs and ECT raise the synthesis and bioavailability of norepinephrine. If your interest runs to pre- and post-synaptic receptor effects rather than neurotransmitter levels, you might hang your hat on the fact that both antidepressants and ECT produce a major downregulation of beta-1 adrenergic receptors. Again, a finding in line with heightened norepinephrine transmission. Incidentally, certain norepinephrine pathways are now known to be more prominent in the non-dominant cerebral hemisphere, which fits in rather nicely with the finding that unilateral non-dominant ECT is more effective than unilateral dominant ECT in the treatment of depression. Since no one would dare leave out serotonin, 5-hydroxytryptamine, I guess I should note that decreased bioavailability of serotonin is thought by some to be a factor in depression. Electrostimulation appears to promote an upregulation of 5-hydroxytryptamine 2 receptors, making serotonin less available. Perhaps this accounts for ECT's effectiveness in treating mania. It's very hard to say, but I give you this as one of the possible theoretical interpretations. A further area of interest relates to the anti-manic and antidepressant effects of anticonvulsants themselves, such as carbamazepine and valproic acid. It is known that seizures themselves have an anticonvulsant effect. This is probably why you frequently need to increase the stimulus during the course of ECT. There's reason to suspect that this effect may be mediated by gamma-aminobutyric acid receptors, and so I guess we can't really forget GABA either. From a neurophysiologic point of view, it recently has been found that cerebrospinal fluid taken from animals undergoing electrically induced seizures has an anticonvulsant effect upon other animals when injected into their brains. Because this post-ictal EEG suppression is reversed by naloxone or Narcan, there is some speculation that this supposed anticonvulsant substance might be opioid in nature. Amnesia produced by ECT may also be opioid related, since there are studies that show, in animals at least, that such amnesia is reversed also by naloxone. From a neuroendocrine point of view, it's worthwhile to note that the anticonvulsant activity of induced seizures appears to be dependent on having an intact pituitary gland. Dysregulation of the hypothalamic pituitary axis has long been known to be associated with depression. Indeed, this is the basis of the dexamethasone suppression test, which has been used to predict the effect of antidepressant treatment. Well, if you're not fully confused by now, it simply means that you haven't been listening. Suffice it to say that definitive answers on the theoretical basis for ECT remain, after about 53 years of use, as yet unclear. I want to spend just a bit of time talking about the stimulus parameters of modern ECT machines. Basically, using the square wave brief pulse waveform, we're talking about 4 parameters: the current, which is the amplitude of each pulse; the pulse width, which is the duration in time of each pulse; the frequency, the number of pulse pairs per second; and the duration, that is the time of onset, from the onset of the initial pulse to the end of the final pulse. This slide illustrates current and pulse width. Depending on the device used, all 4 of these parameters may be varied. Since this is more useful in research than in clinical practice, the machine we use, the Mexa SR2, keeps the first 3 constant and varies only duration. Now, let's talk a bit about the workup and the actual administration of treatment, the placement of electrodes, the monitoring of the patient, and follow-up. Before I launch into that, we might take a little historical tour and talk for a minute about some of the earlier machines. The machine pictured in this slide is the Electra Laboratories Model 160, which dates from the late 1940s or early 50s. Basically, this is a simple sine wave machine which has controls for voltage and duration. Next is a Hitman Medcraft apparatus from the late 1960s. No real difference here, except that it's packed in a rather attractive little white box. Finally, our current Mexa SR2, a state-of-the-art brief pulse square wave machine with electroencephalogram and electrocardiogram monitoring. This is the machine on which we will learn. At this point, let me note that ECT is best administered with a psychiatrist in charge and a nurse anesthetist or anesthesiologist controlling the anesthesia. Theoretically, the psychiatrist could do the whole thing, but he or she had better be prepared to handle all the complications of anesthesia. A personal anecdote might be in order here. Back in 1962, when I was a nursing assistant at a private psychiatric hospital, I used to assist in ECT. Once a patient experienced a glottal spasm, which can occur as a side effect of pentothal anesthesia. I saw the most frightened-looking psychiatrist that I've ever seen. As the patient became blue and we nursing personnel turned toward the doctor to see what he was going to do, he began turning colors himself, and then he almost fainted. Finally, the glottal spasm eased spontaneously, which is what usually happens, but I think this fact might have been lost on that particular psychiatrist. We never saw him do ECT again. The moral is, get an anesthesiologist to help unless you're real good at intubation and advanced cardiac life support. The pretreatment evaluation should include a standard physical examination. Since we only perform ECT on inpatients, this will already have been performed at our hospital. In addition, within 7 days of the first treatment, CBC, electrolyte, urinalysis, SGOT, electrocardiogram, and dental exam should have been performed. In patients with very fragile teeth, the dental service can sometimes make a form-fitting latex prosthesis to prevent tooth fracture. We also require that a pre-ECT neurological consultation be performed within 6 months of treatment. Also, chest X-ray and skull series within 6 months, and a thoracolumbar spine series within 6 months, or following disease or injury to the spine if it's less than 6 months. In our hospital, the ECT workup is clearly spelled out in a Chief of Staff memorandum, and the flow sheet, which you saw illustrated on that slide, each item in the flow sheet must be checked off and then signed by the treating physician and the chief of the psychiatry service. Informed consent must be obtained using standard form 522 in the VA or some other appropriate document in other systems. In particular, it's a very good idea to involve significant relatives in the process, and certainly the risks as well as the benefits must be clearly spelled out. This may take some patience, especially to counteract popular misconceptions about ECT, but it is well worth the time. The patient's ongoing medications must be assessed for possible drug interactions with the pre-ECT medications. In particular, the use of anticholinesterase ophthalmic preparations, of phenelzine, that is Nardil, and lithium should be examined, since these can inhibit the metabolism of the muscle relaxant succinylcholine, with the result of prolonged apnea after treatment. Other undesirable effects can include the induction of status epilepticus with high theophylline levels. Remember, many patients with chronic obstructive pulmonary disease are treated with theophylline preparation, so it's worthwhile to check.